for joining me for my presentation. So it's going to be on osteoporosis. This is really going to help out for the physios, chiros, and the kinesiologists especially. So that's just a bit about what's going to happen during the presentation. We do go into the diagnosis and medical management side of things just briefly. Not that it's too relevant for us, but it's a good idea to know. So we're going to talk about osteoporosis and osteopenia. So osteo meaning bone, penia meaning poverty. So basically there's an increased resorption of bone compared to deposit, which results in decreased bone mass. So the definition of osteopenia is a bone density that is 1 to 2.5 standard deviations below the normal for that gender. Now, if we look at osteoporosis, it's a bone density of at least 2.5 standard deviations below the normal. And osteoporosis, it literally means a porous bone. So you can see on the image on the right-hand side, you have a normal bone matrix and the osteoporosis. So the composition remains normal, but you can see the bone mass is reduced and the bones become porous and brittle. And the spongy bone of the spine and the neck of femur are the most vulnerable to fractures. So this data was actually very, very hard to extract. There's not very clear data, especially on osteopenia. And osteoporosis in Canada, 11 to 12% of Canadians over 40 are diagnosed with it. So that's about 2.3 to 2.5 million. And of those that are diagnosed with osteoporosis, you can see overwhelmingly women are affected far more than men are. And that is actual data from the Osteoporosis Canada. But this other data, 40 to 50% of people over 40 have osteopenia. So that doesn't include osteoporosis, that's just osteopenia. So you can see with osteopenia and osteoporosis combined, quite a large population of people over 40 are affected with low bone mass. But yeah, the exact number is not known for osteopenia because they just don't track it as often as osteoporosis. So yeah, Osteoporosis Canada states that 1 in every 3 women and 1 in every 5 men will suffer a fracture due to osteoporosis at some point in their life or osteopenia. And like I mentioned before, men only account for 30% of all fractures as well related to osteoporosis and osteopenia. And some of the most common fracture sites with osteoporosis and osteopenia are neck or femur. I'm pretty sure we all know someone who's elderly that has fractured their neck or femur, humerus, wrist, and vertebra. And you can see those areas are quite susceptible when we fall. So if we look at rate of fractures as well, the diagram on the left is for women, the one on the right is for men. As you can see, once again, significantly more for the women. And you can see that the wrist fractures are actually more common until the age of 79, and then the hip fractures become more common. You can see by that blue line just there, and that's once again because of falls. So the most common it commonly occurs as a result of aging, and usually 60 to 80% of those that are susceptible is genetic links. So if mom or dad have had any falls that resulted in fractures, it's usually due to genetic link. And then 20 to 40% remain lifestyle related. And the early teen years, especially for women, they serve as a prime years to maximize bone mass. So I even talked to my wife about this, what she knows about it, but that's basically where you build a lot of your bone mass. So it's very important in the teen years and kind of early 20s to build that, I would say, muscle as well as bone mass. Also low testosterone in men and low estrogen in women. And it's usually postmenopausal, there's a higher risk. I'm not going to go through everything here because it is quite a bit, but these are a lot of other causes that doctors have to be concerned with. Yeah, lack of calcium, the obvious reduced physical activity, hormone imbalance, lack of vitamin D as well, and that's what the family physicians usually talk about, the calcium and vitamin D supplementation. Smoking as well, and I've noticed this with my patients, not just the ones with osteoporosis and osteopenia, but anyone who had a fracture and the fracture is healing very poorly, um, smoking is one of the big factors that reduces circulation to the bone and affects healing. So the smokers that just can't quit, sometimes they've, like, I've had a humerus fracture that's just, for, I think it was a 48-year female, and it just was not healing because she was a smoker. So that just affects your bone health in general. But yeah, long-term use of corticosteroids as well, and medical conditions, of course, excessive alcohol, and the obvious older age, early menopause, as we mentioned, and family history. Um, yeah, the other we don't really have to go over. So the prognosis is excellent for people with osteoporosis and osteopenia, with treatment and exercise, of course. Signs and symptoms of osteoporosis. The tough part is it's a silent disease. There's no real signs and symptoms. But if you look at a female who's 60, low BMI, quite frail, you can assume that most likely she's going to have brittle bones and is at higher risk of osteoporosis or osteopenia. And yeah, neck and lower back pain due to vertebral fractures. And some of these fractures that occur, especially in the thoracic spine, are asymptomatic. And sometimes they'll get maybe a lower back pain, and the doctor will do an x-ray and find a wedge fracture at T12. Also, light of or loss of height in patients. That's obviously due to age, and that usually happens due to the chronic dehydration of the discs. But also, if the person's osteoporosis is quite severe, they could get that loss of height just from fractures of the bodies of the vertebra. And other thing to note is increased kyphotic posture, especially in the thoracic region, can indicate some wedge fractures of the vertebrae. And also, when someone gets a fracture with just the slightest trauma, that should be an indication that maybe the doctor should do a DEXA scan to see how poor their bone health is. Oh, I forgot to mention as well, if anyone has any questions throughout the presentation, feel free to butt in. So the pathophys, once again, this is not that, we don't really need to know this, but just for the sake of the presentation, it's good to know that the osteoclasts, they're the cells that absorb bone tissue, and osteoblasts are cells that form the new tissue. And then osteocytes are actually embedded in the mineralized bone. So the osteocytes are actually the cells that communicate with the body to add more bone and not. So osteoclasts and osteoblasts is the biggest thing you should remember. So with menopause, there's decreased estrogen leading to increased osteoclast activity. Osteoclasts absorb bone. And with aging, usually due to decreased physical activity and the reduced activity of those cells, that's going to lead to a higher, there's going to be more osteoclasts and osteoblasts, leading to reduced bone mineral density. 1 second. So yeah, the gold standard for diagnosing osteoporosis is the DEXA scan. That's not really too relevant to us. And also quantitative ultrasound of the heel. That's not really that great of a way of diagnosing. But X-ray is not, yeah, X-ray as well, not for diagnosing osteoporosis, but can reveal osteopenia. And once again, if you look at an X-ray and you see those in an older person, you see a wedge fracture of the thoracic spine without any symptoms, right? That could give you an indication that maybe we should do a DEXA scan. And then quantitative CT as well. Once again, the medical management side, we don't really care too much about, but calcium and vitamin D supplementation is beneficial for all. And the treatment is based on targeting the risk factors. And those are just the two drugs that you would give someone for osteoporosis or osteopenia. There's anti-resorptive drugs and anabolic agents. But other treatment, exercise. So we're getting to the good part here. So exercise, when it comes to osteoporosis and osteopenia specifically, improve strength, improve speed and reaction time, and that's for falls prevention and fracture. So when I'm dealing with a patient that's going to be 70 plus, yes, we're going to do the strength training to build that bone to endure those falls if they do have one, God forsake. And the reaction time, we need that just to prevent the falls. And then by doing that, we're going to be able to improve bone density and strength based on Wolff's Law, which is bone strengthened and remodels in response to the forces that are placed on it. For example, there's a loss of bone mass in astronauts in space for long periods, and athletes with greater bone density than the average population. There was another thing I wanted to note as well. They actually did do a study on people where they actually applied passive pressure on their bones in the same fashion that you would, let's say, doing a push-up. So when you're doing a push-up, you're getting that force through the ulnar and radius. But they actually applied that passive pressure on these bones, and they found that it actually had zero effect on the bone mineral density. So we actually have to use your own muscles to push through the strengthening exercises, because they also looked at this in people that are paraplegics. So like I mentioned before, the osteocytes that are embedded in the bone, they detect the increase and decrease in pressure, and then they modify the osteoblast activity. I haven't heard anything for a while, but is everyone still following? Okay, getting thumbs up.
It's very good. It's very good. Yeah.
Good. So looking at the principles of bone health. So overload, as we know this with anyone, whether they have a shoulder tendinopathy or whether it's for osteoporosis, progressively increasing the exercise intensity is going to promote continued bone deposition. Deposition. I think that's how you say the word. I haven't said that in a while. And also looking at the initial value. So people with lower bone mass have the greatest potential for bone deposition. Same thing if someone has less muscle, it's easier for them to gain muscle because they probably aren't used to exercise. And further bone density gains require greater effort. Same thing with the overload principle. Does someone have any questions? Nope. All right, and
I think you continue, Hardeep. I just sent them, so if they have any question, they can just post it, and then you can answer as well.
Sounds good. Yeah. So more is not always better. So bone cells become desensitized to prolonged mechanical loading sessions, and also reversibility. So discontinuing will reverse the osteogenic effect. So looking at a study, they did resistance training programs on bone-related variables and functional independence of postmenopausal women. And they looked at 3 groups, which was resistance training 3 times a week, twice, and a control group. And I think any more than 3 times a week, it won't be enough time to recover. So that's why they kept the numbers at that. And these sessions, they had 60-minute sessions, and they measured their 10-rep maximum with an intensity varied between 60 and 90%. And there's 3 sets of the mentioned exercises below. So knee extension, leg press, calf raises, squats, hip adduction, glute machine, bicep curls, tricep extensions, and shoulder adductions. And looking at these exercises, especially the physios and kinesiologists, we can see that these exercises are things we can easily do at home with some weights, resistance bands, or just body weight. And this is what the study found, was that there was the greatest increase in bone mineral density in patients that trained 3 times a week when compared to 2 times a week and that control group. And these are just looking at the bone mineral density in those different areas. So neck of femur, trochanter femur, and lumbar L2 to L4. And so another study I looked at, randomized controlled trial of effect of high impact exercise on selected risk factors for osteoporotic factors. So they looked at 98 sedentary females ages 35 to 45, and they did jump training. So that's pretty high intensity. And there was a 16% increase in weight-bearing sites, the neck of femur specifically, when compared to the control group after 18 months. And there was no significant bone mineral density increase in non-weight-bearing sites, as expected. And also looking at a Cochrane review from 2011, that stated exercise intervention is effective at improving the bone mineral density postmenopausal as well. So really have to look at those women over the age of 50. So on men, there, as I mentioned before, not many men suffer from fractures due to osteoporosis. So there's fewer studies conducted on them, but they have a similar response to exercise and treatment as women. And yeah, there's an inverse relationship between physical activity levels and hip fracture rates in men 44 years and older. So outcome measures for people with osteoporosis, we can't really do anything other than have the doctor do a DEXA scan or whatever diagnostic measure they find appropriate for this patient. But in terms of us, like we can clinically reason which patient we think might have osteoporosis or is at high risk of fractures. So strength testing of the quadriceps, grip test, bench press are all good indicators. Even exercises like or tests like squats or stand up from a chair, but also balance measures like the timed up and go tests. I'm pretty sure we're all familiar with that. If not, probably familiar during our school, during our physiotherapy degree or kin degrees. But there's a for that test, the timed up and go. You're sitting in a chair. There's a line 3 meters away, and you're basically timing them from the time they get up, walk past that line, come back, and sit back down. And you can obviously Google this as well, but under 10 seconds is healthy. And also a step test where you place a 3-inch step right in front of you, and you have to place your foot on that step completely and off, and then alternate the legs. And for 15 seconds, you're going to see how many times they can do that. For that as well, 10 steps, less than 10 steps is high risk for that group as well. So general recommendations for exercises for patients with osteoporosis and osteopenia is 2 to 4 times a week high impact resistance training. So you're looking at the 2 to 4 times a week, probably thinking that's a bit of overload if we do 4 times a week, but we're thinking about upper body, lower body when we're looking at that. And train all the structures susceptible to fractures. And we mentioned this before. If I do some squats, I'm not going to gain much bone mineral density on my humerus. And looking at baseball pitchers and tennis players have 20% greater bone mineral content on the dominant arm, the throwing arm. And also cross-country runners have a greater lower limb bone mineral density and content. Also looking at the site-specific effect as well. A lot of people, especially older women, they say, "Oh, I walk a lot." And the research actually showed, I didn't mention it here, but walking only maintains bone mineral density, but then over time it still slowly goes down. So walking is not that great at building bone density. So we have to start adding in some higher impact exercise or resistance training. Also maintain an adequate vitamin D and calcium intake. That's for the doctor to ensure. And incorporate, like I mentioned before, incorporate balance exercises for fall prevention. So examples of exercises, right? So we're looking on the left-hand side at those common areas of fractures, okay? Neck of femur, humerus, radius, tibia, and fibula, and the vertebrae. So I get a 65-year-old female, let's say, she's never exercised before, right? And we're thinking, man, we got to work on all these sites if they are osteoporotic. And you can see on the right-hand side, a lot of those areas are covered by just 3 simple exercises, right? In a push-up, she probably can't do a knee push-up. We can start off with a wall or a countertop push-up. And that principle I mentioned, overload, right? Slowly start building up. Deadlift seems pretty intense for a 65-year-old, but let's place something in her hands and just teach her to pivot from the hips, right? And also including the squat. So you can see all these exercises, and they're doing a goblet squat there, so that incorporates the upper body. But all these exercises can hit all those common sites of fractures. So treating osteoporosis and osteopenia, when you incorporate exercise, not too hard, just progressively overload your simple exercises. Biggest thing I tell patients is don't overcomplicate things. Just stick to something simple, just slowly start working on it. And like I said, that's not just for osteoporosis and osteopenia, but just strengthening in general and any other musculoskeletal condition that they might be dealing with. And I do have an example of a I was actually a kinesiologist. This is in 2014. I had an 84-year-old patient. I used to go to her house for trainer because I was working in the community at the time. And compliance was a big issue. I would see her 1 to 2 times a week, was not doing her exercises. She lived with her sister, who was also elderly, and would kind of squeal on her and tell me she's not doing the exercises. But based on her objective measures, I knew she wasn't. But then we ran out of sessions from ICBC. A month later, I followed up with her when we got approval, and she was initially walking with 2 walking sticks. She was at no walking sticks now. And the only exercises I gave this patient was sit to stand and lateral walking. Lateral walking with support on a countertop. 2 exercises I gave this patient, and she was able to go from 2 walking sticks to none. Because ICBC was not approving many sessions, I saw her a month later, keeping it up. Saw her a month after that, she dropped off on the exercises. She was back on 1 stick. Followed up another 2-3 weeks later, she's back on 2 sticks. And her sister had told me she just stopped her exercises completely. A year later, my employer at the time, he's an occupational therapist, informed me that that same patient, who is now 85, went back to India to visit family, fell, broke her neck of femur, and passed away, unfortunately, in India. So I always use that example for patients on the importance of working on these sites, right? Because fracturing, especially the neck of femur, not many people over the age of 70 survive that. All right. Any questions? Well, I haven't had any questions yet, but feel free to shoot them.
So I was just wondering about the I asked you in the group, in the chat as well. Did any of the studies show like any functional improvement, or was it just bone mineral density that improved?
So you're talking about measurements like the timed up and go and the step test?
Yeah, but even like something that's functional, did the studies go on talking about like, falls being decreased, or
The measures
improved or anything like that, or?
This look just at the bone mineral density, the ones that I've
Oh,
seen.
Okay.
Yeah, but the amount of research on falls prevention as well, there's quite a bit. And I actually did I remember back in school 8 years ago now, I looked at just the sit to stand exercise for falls prevention.
Okay.
And I found many articles that showed significantly reduced falls risk just with the sit to stand exercise. So if one exercise I give my elderly patients as I discharge them is spend 10-15 minutes teaching them how to do the exercise appropriately, how to progress the exercise. But yeah, you would assume that looking at the studies that I mentioned, if someone is increasing bone mineral density with resistance training or high impact exercises, it's going to improve their function as well.
For sure. That's perfect.
Kasir?
I have a question. What do you think about, or what do you say about this full body scans? These days people do it to check their bone density scans, and then what do you say about that? Is that a good idea to do?
Are you referring to DEXA scan or like the full body MRI?
No, it's like a full body thing, right? They tell you about your fat and muscles and everything, right? And then your bone density as well.
So this is actually a scan, like not an MRI scan?
I think it's a non-MRI. I just have a link. Someone, there was a doctor. He's doing something about nutrition. So he shared this with me that, it's a great thing because it tells you about your bone density, your protein, your muscle mass and something. And then, then I'm doing it and I'll do every 6 months to see. So that was a kind of,
I don't know. What I would think about that is that would be appropriate for anyone over the age of 45 who is already physically active, right?
Yeah.
Why would one privately pay for something like that when you haven't done your basic stuff, which is focusing on diet and exercise to work?
Yeah, absolutely.
Strength. It's kind of like me not exercising, eating healthy, but then supplementing with a bunch of different types of supplements, right? When I'm not really working on the foundation at the end of the day, which is for any patient on overall health is going to be sleep, eat, and exercise, right?
Yeah. And then about the deep tissue massage, for example, there's a kind of concept that, with osteoporosis, like, be careful, be gentle, and Is there anything about this kind of stuff, where there's any literature on deep tissue release? And
I would think that there's no literature. I haven't seen any literature on that. There would be literature on that and manipulations.
yeah,
Because when it comes to, if you're doing like a grade 4 or less mobilization on a patient, right? Not just deep tissue, but mobilization. It'd be safe to assume that they're walking around and mobilizing without any aids, that there's no force that my hands can put in that could possibly fracture a site. But obviously there's still a lot of damage that we can do with our hands. There's actually a body worker, the video of a body worker in, I believe it was in China, and he had that patient in a Faber's position, and applied a bit of gentle pressure in the Faber's position, which actually fractured a neck of femur. And the patient unfortunately passed from that. But I haven't looked at anything with deep tissue related and osteoporosis. I would say more so the mobilizations and manipulations.
I think you're deep. Those those high velocity, manipulations.
Yeah.
All of them are kind of, need to be careful about that. Yeah.
Mm-hmm.
Guys, ask questions from Hardeep. If you guys have any questions.
Everyone's good?
No questions? All right. Okay, Hardeep, that was wonderful. That was a great presentation.
Thank you.
And, we really learned a lot from it. So thank you so much. Thank you for that.
Yeah. And
Yeah.
everyone for listening. I'm glad to
Yeah, that's awesome. That's awesome.
All right.
Thank you. Thank you so much, guys. Thank you for joining. Thank you.
Yeah, have a good night, everyone.
Take care. Take care. Bye. Good night. Good night.
Thank you.
Good night.
Thank you.